All right, let's move on here and let's bring on Dr. Adam Kaplan, the Chief Scientific Officer of MyMD Pharmaceuticals. There he is. How are we doing today?
Good. How are you, Spencer?
Doing great, doing great. It's been a minute since we caught up, so good to see you again. Hope your Thanksgiving was well. Let's bring his slides up on the screen, guys. There we go. And Adam, take it away.
Thanks so much, Spencer. I also wanted to make sure that my colleague, Rob, who's the brainchild about all things financial, is hiding in the wings. So he's my fall guy. He's my net, and I never perform without a net.
He is lurking backstage. Yes, we'll bring him on in a little bit.
Excellent, thanks. So forward-looking statements for those people who are, bearish about forward statements. So let me give a quick company overview here. We have two drug candidates, MyMD1, which is a clinical stage immune regulator. I'll tell you mostly about that. And Supera CBD, which is a preclinical patented synthetic cannabidiol derivative. It is like its name implies, it's a super CBD. And I'll put some data where the name is in just a minute. We are currently set to begin 2 phase 2 trials in the first quarter. We're already screening for one of those 2 phase 2 trials at Johns Hopkins. This is our advisory board. Just in the interest of time, I'm not going to linger there. Excellent, experienced group. I myself am from Johns Hopkins, where I was for the past 2 decades. Studying autoimmune diseases and the like. So these are the guys who know everything about business. I'm the science guy. And I'll let Rob touch base on the financials. Essentially, this is the same thing, which is just to give you connecting the dots through the TNF alpha component of the MyMD1. It is been shown already in published studies to decrease TNF alpha as well as IL-6 and IL-17. Why is that interesting? Well, it turns out TNF alpha is the $40 billion a year market that Humira alone, one of the 5 drugs that's available, accounts for $20 billion a year. It's the number 1 grossing drug in existence at present, and they treat autoimmune diseases. What's different about our drug is it's an oral drug as opposed to injection. It crosses the blood-brain barrier and it doesn't affect the ability of the cells in the blood to mount an attack when bacteria or viruses or fungi invade. So, we think that the safety, the tolerability of the oral medicine, and the fact that we can access the CNS, the brain and spinal cord, gives us advantages over the currently available treatment. So again, it is, since TNF alpha is the kind of king of inflammation, it's the first pro-inflammatory messenger that the immune system produces. Even from birth, we're ready to mount and attack any invaders that come in by what's called the innate immunity. You don't need to adapt or acquire this later. You're ready to go. TNF alpha is the leader. It's the first one up. And again, we sort of discussed the big grossing here, Humira, but even some of these smaller drugs are multi-billion-dollar drugs. Big area. So we think we're really sort of getting at the causes, not just the symptoms, not just because of TNF alpha, but because there are separate drugs out there for autoimmune diseases that also hit IL-6 and separate drugs for IL-17. We in one drug do all 3. So again, we think that that offers some benefits. That selectivity is really crucial. Unfortunately, the drugs, the TNF alpha inhibitors, for instance, all have a black box warning for severe infections, because if you block the ability to, ward off infections in the blood, then you're risking not being able to quiet down an infection, an overwhelming infection. And so it's severe infections, the black box warning, up to and including death. And death is not something you want anywhere near your package insert. There's also antifibrotic effects, which is very interesting. About 40% of deaths in this country have fibrosis involved. So think of this as scarring, things like cirrhosis, which is scarring and ultimately overscarring of the liver. You've got kidney disease that involves scarring, cardiac disease, lung disease. All of these involve over healing. So it's kind of healing gone on steroids, healing gone awry, that lead to this scarring. And MyMD1 is a potent inhibitor of this fibrotic in vitro studies. We are now interested in the potential applications of this for other studies. Also, since it turns out that the best evidence I can give you that inflammation is associated with depression is that a study came out of Harvard about a year ago showing that post-COVID infected individuals at 3 to 4 months out, 50% of them will have moderate to severe depression. That's a lot, and it's because of inflammation. COVID doesn't kill you. What COVID does is create a cytokine storm. It activates the immune system, and it's your immune system, kind of like the sorcerer's apprentice out of control, that then overwhelms the body and causes death. It also, at lower levels, causes depression, and so post-COVID depression is one of the treatments we're going for. There is a study, this is just early examples of some of the data from that study, which is currently in submission from a major academic center. This just shows you that here, taking mice, the equivalent of about 60 years of age, treating them to about 85 years of age. The red curve shows that at time 0, 100% of those mice were alive. 13 months later, the majority of those mice are alive. That's in contrast to rapamycin or rapamycin plus metformin, the two other drugs that have been shown to slow aging and extend life. And you can see by the end of the study, they're all dead. So that's a pretty big on or off kind of phenomenon. People ask me, gee, am I taking it? And until we have better data, I am not. But I certainly will tell you that this is something, if this holds up in humans, what it does in mice, this would be a real boon. Because of that, by the way, we are going for the equivalent or the surrogate marker of aging, which is muscle loss and frailty. Frailty is a combination of muscle wasting and increased susceptibility to falls, cognitive impairment, these kinds of fun things that happen when we age, if we age in a way that is pathological, normally due to increased inflammation. And so the FDA has indicated that we can go for, we have an IND approval to start this study in sarcopenia and frailty, starting in January, just coming up a month from now, to begin the process of working our way towards an aging, decreased aging phenomenon. So Supera CBD, we'll just cover this in broad strokes. Supera CBD is a small change. As you can see here, the CBD is on top. You can see it has that 6-member ring, 2 6-member rings, but on the top right is a 6-member ring that if you go down to Supera CBD, the only difference is that 6-member ring turns into the pentagon. It's a 5-member ring. And that one small difference immediately has a difference here. So it turns out all cannabinoids, whether it's marijuana, which is predominantly THC with some CBD in it, and 100 other chemicals, they all work through either the CB1 receptor or CB2. When you think of THC causing the intoxication, that's CB1, but it also helps with anxiety and pain, but you do get intoxication and the cognitive impairment that goes along with it. And when you think of CB2, that's the immune system. It's the break of the immune system when you take drugs that activate CB2. As you can see in this already, CB2 is where the money end of Supera is 92% inhibition. That's compared to 25% of CBD on the left. And there's a slightly lower THC kind of CB1 activation, 39% in Supera compared to 54% in CBD. But the thing is, it's not just whether that molecule, that drug, binds to that receptor, the CB2. The question is, once it's bound, does it activate it? Does it inhibit it? And does it have a potent effect? We were shocked to find that the effect of this drug, remember, just taking that 6-member ring to a 5-member ring, led to an 8,000 time greater potency at activating that receptor. So it's kind of hard, you get a degree in neurochemistry here, if you can follow all this. But here in the middle, you see Supera CBD. You can see that the EC50, the half maximal dose to have an effect at activating that CB2 receptor is 0.004. That's in contrast to CBD on the right, where you can see you got to go out to 30 micromolar before you start to see any effect at increasing that thing. So if you take 30 and you divide it by 0.004 or 0.003637, you get 8,000, and that's the level of difference. So Supera really is super and superior in this way. So studies have demonstrated, comparing it side by side with CBD, that, and this is what we're working, that the binding and activation is really different. We also have evidence already that says Supera CBD is great for anxiety. So this is in animal models. We are not yet done with our phase 1 safety studies. We are in the process of moving forward with those. So this is a step behind MyMD1. We're still doing preclinical and safety studies here. But it looks to be a molecule that has incredible potential to not just do what CBD does, including anxiety. CBD is now approved as Epidiolex for types of rare adolescent and childhood onset seizure disorders, so as an anti-epileptic, and the host of other potentials that you hear about routinely on television and in the news about the things that CBD might be able to do. And we think Supera not only might be able to, we think we will find the indications where it really is dramatically better at doing what it does. So those are kind of the highlights. I think we covered this. And Rob, do you want to come on and just make some important messages about the finances? Can we get Rob here to kind of bring us up?
Sure. The good news is we're fully funded. We have, as of the last September quarter, $16 million in cash. And I think one of the keys here is we'll be starting this aging trial right after the new year, and we'll have data by the end of the first quarter. So, you don't have to worry about running out of money or anything like that. We have this all fully funded.
So Spencer, we're happy to field any questions. If people have questions, that's kind of the highlights here. If there's anything you wanted to add, please let us know.
I would just say, generally speaking here, this could be for either of you, maybe for Adam. What is sort of the most difficult thing right now?
The most difficult thing. So, again, the difficult thing let me take each drug separately. The difficult thing about MyMD1 is that the excitement that surrounds having a drug that, as you can see from the data, one thing I had forgotten to mention, very important, is it doesn't just extend the lifespan. These mice are fit, and so it delays aging. They maintain their same muscle strength throughout the entire 13 months, which is remarkable. So it's not just coming up with a drug that's going to make everybody demented and old. It slows aging. That is the holy grail, right? Because if you get rid of all cancer, you still have only increased lifespan by 3 years. Why only 3 years? Because if cancer doesn't get you, lung disease will. As you get older, they all go up, all of these risks. So aging, if you can hit aging, that's the way to solve all of the problems. The problem is it's very hard. There are no drugs that have approval for aging, so we're in virgin territory. And it's not that other people aren't trying, but so we really have to use these surrogate markers like sarcopenia and the like. So that's, being in an area that there's no path there. For Supera, the difficulty is that here we've got a molecule. We know how safe cannabinoids are in general. all of them. And the frustration is having to go through but that's the way the game is played, but having to go through all of the safety data. I'm just so excited by it. I'd love to get it into human studies, but the system is designed to prevent us from missing anything that was unanticipated. But you're just asking me what are the difficulties from my standpoint. The difficulties are that it's going to take time to get what I think could be a super cannabinoid to clinic. That's the frustration.
Is the goal to make these available outside the U.S. as well?
Yeah, absolutely. So we don't have our in-house patent lawyer here with us, but he's done just a phenomenal job. And I'm just going to throw a number out there. I think it's 14 patents for MyMD1 and perhaps another 15 some odd patents. We've already been granted a host of patents, I think 8 patents for MyMD1 and a couple of patents for for Supera, but we already have heard back early from some other countries regarding patent approvals for both molecules.
And then and the last one here from the chat, how would I'm not sure which drug is being referred to here, but let's just assume both. How would it be administered? I guess.
Yeah. So again, great question.
Up on the screen.
Yeah, great question. So again, just to reiterate, one of the huge advantages of MyMD1 is it's an oral medicine. It's a small molecule. It gets across the blood-brain barrier. Huge advantage over all of the other anti-TNF alpha drugs, which are either injections or infusions where you got to go get hooked up to an IV. And with respect to Supera, it also is an oral medication, at least on first blush. That doesn't mean, once we get to human studies, we may be able to find out that, nebulizing it or, other means of delivery might be preferable. So we just have to wait and see how that goes. It's a good question.
Got it. All right. So Adam, Rob, MyMD, guys, thank you both so much for joining us on the final Benzinga Small Cap Conference of 2021.
Thanks so much, Spencer. We appreciate it.